Thank you very much. I just got in last night from the Florida Orthopedic Society, and where I'm the chairman of sports medicine, and I did want to bring everybody up to date on some new developments that are going on in the state in the world of sports medicine. In January, we had the first meeting for the Florida Alliance of Sports Medicine, and we really had assembled there all the major orthopedic players in the state. And out of that, we have the support of Senator Bill Mumford from the state legislature and Roger Deering, who's going to be here with us today with the SHAAA. So I think we're on the verge of being able to finally do something statewide. We've been a little bit frustrated having no great organization to push this forward. The first educational program is tentatively set up for July 26. Look for some information out on that. I seriously doubt that it will come off quite as well as this event today. And before I get started, I'd like to have everybody give a hand to Bob Sefcik and Jim Mackey for this great performance. I'm actually a sub today. The original speaker was Mike Ryan, and if many of you know, Mike is the head trainer for the Jaguars. He's also one of the healthiest, most fit guys I've ever met. I think he might be down training the Navy SEALs in San Diego, or at least training with them, and he said it was an opportunity he couldn't pass up, and I can't say that I blame him. Mike's a guy that really got me interested in exercise. When I was a team physician for the Jaguars, he was the most fit guy I ever met. He would ride his bike in from the beach to work every day. On the weekend, he'd ride down to Daytona to see his mother. We would go out to dinner, and while I'm getting my cheeseburger and fries, he's eating the healthiest stuff I've ever seen. You know, I was a very busy orthopedist. I didn't have time to exercise, and Mike got me interested, and since then, you know, my wife and I have run 10 marathons, and we've been very active. And although I'm a lot older, I think I'm a lot fitter than before I met Mike. So it's a shame he couldn't be here with us. But today I'm going to talk to you a little about a more mundane thing than we heard earlier. This is for every one Reuben I take care of about 5,000 of these things we're talking about today. So we're going to talk a bit about running injuries. And for those of you who do like exercise, running is really the most common and efficient form of exercise. But it does have some frequent overuse problems. Serious injuries are very uncommon unless you happen to get hit by a car, which is a rare occurrence. We want to start off on any running program with talking about prevention. And while there is some controversy, and I had the occasion to talk over at First Place Sports about this, I think most people still agree that there's some value in warming up and stretching. You know, if you don't believe it, tear out in the morning about 5 or 6 in the winter and go run yourself a hard 5 miles and see how that works for you without any warm up. So really what the current thinking is, warm up, do something, get on a stationary bike, walk a couple of blocks, stretch, and then start running. Now, stretching is something you don't have to just do before or after. Stretching is something you can do anytime, and a lot of the injuries that we see from running is because as most of us get older, we get a little tighter. Some of us are looser, some of us are tighter. And you know, it always begins with the most commonly injured things, such as the hamstrings. And there are many ways to stretch hamstrings, as illustrated here. These ropes are great for it. ITB is another very frequent source of running problems. There's several good stretches for that. You want to teach all your runners. And I actually bought one of these boards, much to my wife's chagrin. I keep on my front porch before I go running, but a step or stair will do just as well. The neat thing about running is you know, if you're a gear freak, it's hard to gear up too much, but you can do it. But really, you just need some shoes. Some of us need some orthotics, but it's pretty cheap. A good pair of running shoes, somewhere around $90 or $100. You can really overextend or a little more, but it's not necessary. For those of us that are getting up in age a little, you really need a general medical evaluation. We recommend a stress test or cardiac evaluation for people over 40. And it's just with our pre-season physical examinations we do for our high schools, you know, the history is the most important. Passing out, syncopal dizziness, any of those things, history of sudden death in the family, those are the things you're really looking for. And then you want to look at the general alignment of people, and you know, this classic triad of internal rotation of the femur, valgus, increased Q angle, pronated feet, you know, that used to really be the kiss of death for the people that were built this way. However, with the newer shoes, orthotics, and some of these newer techniques, Galloway techniques of walking and running, I've seen some of the most god-awful looking people out running, doing half marathons that you've ever seen, and they can do it. And so, whereas this used to take one look at somebody like this and say, buy a bike, you know, we now can see people doing a lot more things. You know, for runners, you know, overtraining and getting fired up and doing too much, increasing the mileage, deciding you're going to do the Donna Hicken half marathon and every year before the river run, and before any of these things, the office gets filled up with people with aches and pains and things such as stress fractures. But the stress fracture is something when you see someone that has kind of a weird pain. You know, sometimes it's a weird groin pain, sometimes it's a pain that they can't define in their calves, sometimes it's some kind of weird thigh pain, and as you're poking around on it, you really can't put your finger on it. Those are the things you worry about as stress fractures. A lot of times the x-rays are negative. We see most of them in the tibia, but you can see them many ways. I tend to like bone scans for diagnosis a little more than MRIs. They used to be cheaper. I don't know if that's still the case as the price of MRIs have come down. And the treatment is pretty simple. Rest for 6 weeks. But remember, that's a bell curve. So, you know, some people aren't going to be well at 6 weeks. And if they go out and start running and they start having pain, they just need to back that up a little bit. This is an example of a normal tibial x-ray, but a very hot bone scan. And to me, this is diagnostic. Sometimes you can get these early and you'll see a scan on one side that's very hot, but on the other side, you can see a spot that isn't so hot, and that's maybe an early stress fracture or stress reaction. Those types of milder things may get well in 3 or 4 weeks. Most of the time, they're not going to be in your office, but occasionally you will see one that comes in a little earlier. The other frequent thing we see, and as orthopedists that see knees, this is, you know, the most common thing all of us see. And in my little knee owner's manual, when you go to Chondromalacia, you're looking for it. Some of the older ones and some of the ones currently, they call it runner's knee. And it's really anterior knee pain. You don't necessarily have to have patellofemoral crepitation, but a lot of them do. The treatment's fairly simple with therapy, nonsteroidals, and I've been very successful with runners taking glucosamine. I've been taking it for probably 15 years, and it does seem to help that milder pain. I think that while it's a little controversial whether this thing does everything that the GNC people say it does seem to have a mild anti-inflammatory effect, and a lot of patients really get a good relief from it. And this is the type of thing that you always, if you're having somebody with knee pain in a runner, you want to look at their feet, because the foot pronation can lead to this runner's knee. Again, the ones that have one knee that's really crunching and one knee that's not are a lot harder to treat with therapy than the ones that either their knees are about the same with a mild amount of crepitation or they have no crepitation. The ones with no crepitation, usually it's just a matter of stretching and strengthening, and you can get them back working. And again, you know, there's a normal supination, pronation in a runner, but what you're looking for is excessive pronation. And the supination is more in the high arch where the foot's cupped up. And then the pronation, most people will pronate as they roll off their foot, but what you're looking for is the overpronator. Now, shin splints are something we see in runners, but I think that probably one of the worst shin splint cases I saw was in a JU female soccer player. So it's not a running specific injury, and it can be very debilitating. It's pain along the anterior medial border of the tibia. You want to rule out a stress fracture. A lot of times I can put one finger on a stress fracture along the posterior medial border of the tibia, but shin splints are usually over about a 4 to 7 inch, and that's from a physical standpoint, that's sort of what I'm looking for, is more of the more diffuse tenderness along the posterior medial border. A bone scan sometimes can show a very light uptake along that, and you can actually have a bone scan that is diagnostic for shin splints. The treatment is usually rest therapy, and this is where the orthotics come in. The pain is usually along the posterior medial border of the tibia, again over about a 4 to 7 centimeter or inch area. Again, the differences in shin splints is what you're ruling out stress fracture. Shin splints orthotics are very helpful, and they come in a variety of ways. The local brace shops, the orthotists make them, the podiatrists do this from their offices. Many of our physical therapy places have relationships to where orthotics. You don't necessarily have to have as many as I do, but these are probably only half the ones that I have. But starting from, these are some I did get from a podiatrist. These are sized, 7, 8, 9, 10. These are custom but street orthotics, and the rest of them, I think the boys at Foot Management said the only person that got more orthotics than me is Shaq, because every 2 games Shaq had won a new pair of Foot Management orthotics, because he said he was so big he wore them out. And they finally just started taking them back and putting new decals and sending them back so he'd shut up. I go through a pair probably every 6 months, and I can tell when they start packing out because I get heel pain, but I found them very helpful. And my problem is plantar fasciitis, and that's probably Dr. C in my office. I think he limits the number of plantar fasciitis that he sees a day, because just like back pain in an orthopedic office, you can fill up your whole schedule with back pain. For the foot and ankle specialist, you can fill up your whole day. Seeing plantar fasciitis is so common. It's really heel pain at the bottom of the foot. Morning pain when you first get out of bed, very common. The spur is sort of an optional deal. Some people have it, some people don't, and it's not the cause of the problem. And the treatment is a lot of times just supporting the arch, and one of the easiest ways is to stay in running shoes. Some of your ladies don't look too good at work with your dress and running shoes, but when your feet get hurting, that's one of the best things. And sometimes if it's really bad and just walking barefoot on hard floors, you can get flip-flops now, Reeves or sandals, that you can use them around the house in the shower, so you're keeping your feet from hitting the hard surfaces. Again, the spur that you see is a traction spur, and it's just it forms because of that arch tugging and getting microscopic tears as the arch attaches onto the heel, and the spur gradually forms. But again, it isn't a spur that's sticking down. That you may feel like it's a spur that you're sticking down, stepping on, but it's really not the problem. Non-steroidals seem to help this, but it's not something you need to be on a long-term basis. Well, what other things are hot and out about running that's new and different? And I think the barefoot running craze is still in its boom right now. Certainly the people that sell shoes can attest to that. And again, the problem with this is that most of us during the day are in well-supported shoes. Those of us that are in clinics and on our feet all the time do either have orthotics or aren't really in flat, hard shoes. Ladies, the heels. We're not like our Masa warriors here that run around barefoot. And so we've really taught our feet to be lazy. And the muscles really of our feet are supported all the time. And we're really not built to run the speeds that people run. You know, the human, they used to trot to get from place A to place B. And as you have to run faster, you almost have to heel strike at times. And so we really weren't designed to land on our heels, and that's caused a lot of the problem. So in the way that we're running faster and we're supporting our feet in ways that make them lazy. So the problems that this can occur are all if you listen to the barefoot runners and the minimalist running people, part of the problem is that this heel striking can lead to stress fractures, Achilles tendonitis, runner's knee, blisters, all the things that we're used to. So what does barefoot running do for you? Well, it definitely helps build up your muscles, but you know, I've seen people out on the road barefoot, but you know, there's glass, there's pebbles, there's rocks. The best kind of barefoot running, and a lot of our cross-country coaches will take out the teams on the golf courses, beach, and you really ought to start very limited at first, and it certainly helps to be younger to do this. The golf course is an ideal place to run if you don't get run off by the pros. These are the classic barefoot shoes, the Five Finger by Vibram, which have the potential to protect your feet, but are still pretty barefoot. I was up at Grandma's Marathon a couple of years ago, and this guy running by me, and I look down, I see these things, and I just said, well, how are these things doing? He says, well, I've only run 6 miles in them before, so we'll see. I saw him at the finish, so he made it. But you know, if you go in a running shoe store, this is a whole wall in First Place Sports of the various minimalist running shoes. This is a hot seller of shoes, and they come in various support. But the key to them all is your heel sits lower, and they're designed for you to run on your toes or run flat and not really heel strike. What we're seeing so far is these may be a better tool to improve your running than the ultimate solution, because while there are some people that can get away with this and really like it on a long-term basis, the key is to getting off your heel to strike more of a flat or forefoot strike, and that lets you absorb a lot more shock. So what other things do we see in our runners that we also see in plenty of our other athletes? And the iliotibial band is really a bane of runners, and it's lateral knee pain, and if it gets you, you really can't run through it. It's like, you know, it's been described as somebody taking an ice pick and stabbing it in the side of your knee. And if you do try to run through it, it can turn into a chronic event, and it can really shut you down over a period of time. So for us, we want to make sure that they don't have a lateral meniscus tear. We want to rule out any stress fractures. The therapy consists of stretching, exercises, non-steroidals, and some of the newer topicals. This is an area I'm not so sure that you're going to get a topical through your heel pad to your plantar fascial attachment, but there's very little fat over the iliotibial band. Some of the topicals, and ice massage is extremely important for these iliotibial bands. Again, it's a pain there on the lateral side of the knee, and it comes from the movement of the iliotibial band. Now, cyclists get this as well, and occasionally you can even do a shot in this area to try to cut down on the inflammation. But basically, you got to give it time, get over it, and then can return to running. The only year I ever beat my wife in a marathon, I had to shoot her up for iliotibial band in somebody's backyard in Hopkinton. And I saw her staggering around looking for the medical tent at the finish because it wore off about 2 miles from the finish. But she was determined she wasn't going to let me do it without her. Achilles tendinosis or tendinitis is something that we don't see as much of here because we don't have hills. It's in the areas like Atlanta and the areas that are very hilly, they see much more Achilles tendinitis than we see here. And again, it's from the impact. We see it a little more in people with cavus feet, some in hyperpronation. A lot of times you can feel the thickening in the Achilles. And this is, again, something that's very difficult to run through, you know, and it is something that takes a long time to get over. You can see actually thickening or damage in the tendon on an MRI. The therapy and treatment, again, is to decrease their activity. Cold therapy, deep massage in this is very helpful. Occasionally you can actually do, there are various ways surgically to either cut out the necrotic or dead tendons, which is very rare. There's some radiofrequency devices that you can put in to try to eliminate that. But, you know, I think some of our newer massage techniques have been very, very helpful at improving this and getting this better. You know, it's a hard sport to find that you don't see these muscle pulls. Hamstring, calf, and the quadriceps are the big three that all of us see. I think we know empirically that we don't want to stretch them immediately. We want to give them 2 or 3 days of rest. Sometimes it's probably helpful to hold off on the non-steroidals for a few days just to prevent bleeding into the area. Gradually start stretching, start strengthening. This is the area where this Graston massage has been magic. I think it's one of the biggest advances that we've had in the treatment of muscle pulls since I've been in sports. Certainly at times on the West Coast they were very big on injecting hamstring pulls in professional athletes with steroids. The latest thing is injecting them with PCP or ACP. Again, it's hard to find in Jacksonville somebody that will give you $600 because something might work. I think they line up in Los Angeles to give them $1,500, but I think Jacksonville's too cheap for that. There's no definite evidence. It's a nice idea, it might work, but so far I don't think we have any evidence of that. And then we have got some laser treatment on this, and so far that's been very promising. Again, this Graston massage is massage with these dull tools. It breaks down the scar tissue and is really, not that you can't do it manually, but it seems to be a much more effective way to get rid of these knots and break up the scar tissue. And it's something that you can have done and go out and run the next day, which the runners obviously like. And at least for my personal treatment, has been extraordinary. The laser, again, this came out a few years ago. I don't think anybody knew too much about it, but we've had this now, I guess, 6 months, and so far the applications on these muscle pulls have been very promising. You know, in dealing with runners, you have to deal with the runner's mentality, and telling them to rest is difficult. And, you know, that's one of the reasons they come to us, is that if they go to their primary physicians and they're just told, well, just don't run for a month or two, you'll be fine. And that doesn't get it. So you've got to find a way to let them do some cross training. And you know, a lot of times you may not be able to run, but maybe you can cycle, or maybe you can elliptical. You know, for those, the most rewarding patient for me to treat that are runners is a triathlete, because they are perfectly content to go swim and bike if they can't run. But you know, in the winter and over the course of a lot of runners, not a lot of them can swim, but the ones that can, it's certainly easy. Just going into physical therapy and going into rehab really helps their mentality. And as you treat them, you know, if you can encourage them and get them back, you know, the underwater treadmills, the zero gravity treadmills, that's all a real advance, both in the terms of their rehab and even more so in the terms of their mentality. And so those things are extremely important. So the goal on all of our athletes, and particularly our runners, is to get them back running. And one of the things that some of these new techniques in running, such as the walk-run philosophy, I don't know that you're really going to run a under 3-minute marathon walking and running, although they say you can. But it is great for these runners returning from injuries. If they have an injury and you can get them to run for 3 minutes and walk for a minute, or maybe run up to 5 minutes and walk for a minute, it really gets them back much faster. It's something that at first wasn't very widely received, but now I think is when you're out on one of these marathons, there's probably a fourth or a third of the people that are doing it. It's very well received, and it really, really helps these guys as they're coming back from injuries. Any questions? Okay, thank you very much.